Okay, the next entity we'll be talking about is the malignant peripheral nerve sheath tumor. These can arise de novo, or they can arise from a peripheral nerve or from a neurofibroma. Half of these, 50%, are associated with neurofibromatosis type 1. And it's typically a deep soft tissue tumor. So, you can see them, they can present as a mass typically. And when you do see involvement of the skin, it's usually secondary to direct extension from a deeply located tumor. Rarely do these tumors arise from schwannomas or ganglioneuromas. So most of the time they'll arise from a peripheral nerve or from a neurofibroma. There are primary cutaneous malignant peripheral nerve sheath tumors, but these are rare, and they usually arise from malignant transformation of a pre-existing neurofibroma, particularly the plexiform variant. They grow very gradually. They typically asymptomatic. But anytime a patient reports sudden enlargement in a pre-existing neurofibroma, you have to think about this entity. It has a very aggressive course. Frequent local recurrence and distant metastases are characteristics. So histologically, what you do see are these spindled cells that are organized in what are described as sweeping fascicles. So this is a deep soft tissue nodule, a portion of a soft tissue nodule, and there really isn't any overlying epidermis or dermis. But on higher power, the composite cells are spindled in nature, and they're organized in what have been described as sweeping fascicles that are arranged in somewhat of a vaguely herringbone-like pattern. And I'm just going to kind of scan around. I don't know if you can appreciate that sort of vague herringbone-like pattern to the arrangement of the cells. You can also see very hypercellular areas that kind of alternate with hypocellular areas. So you can see densely cellular areas here and then more hypocellular zones, and they kind of alternate. Sometimes you can see areas where there is some nuclear palisading, almost reminiscent of our schwannoma, but that's not really appreciable in this example. But typically the cells demonstrate some cytologic atypia, including nuclear atypia. You'll see some pleomorphism of the cells, and you'll also see an increased number of mitotic activity. So you can see that some of these nuclei are quite large, and some of them are also hyperchromatic. There's a mast cell right there. So mitoses can be as frequent as up to 4 mitoses per high power field. Let's see whether we can find. And in this view here, we can see a couple of mitoses already. So there's one here, and there's another one there. So once again, a very spindle tumor, but what distinguishes it are the densely cellular alternating with the hypocellular areas, and that herringbone-like pattern to the arrangement of the spindled cells. These cells are usually going to be S100 positive, but typically it's focal and weak, and only half of these tumors will express S100. So it tends to be a diagnosis of exclusion, and it's identifiable by noting that most of the other markers that one might consider are negative, with the exception of S100, which can be negative in half of these cases. So it requires careful correlation with the clinical story and then the ruling out of other spindle cell neoplasms with immunohistochemical markers. So this is a malignant peripheral nerve sheath tumor. In this example, I have an S100 stain, which shows only very patchy expression. And so this is the S100, and you can see that most of the spindle cells are really not picking up with the S100. So it's very focal staining, very patchy. Not the nice diffuse staining one would like to see. So important to recognize that.